Hi, I'm Andrew Holden from Auckland, New Zealand, with the team here from Auckland Hospital, and it's a pleasure to introduce a case of AV access intervention and using a high-pressure balloon, in fact, the Boston Scientific Athletis balloon. We're delighted to be able to use this device in this patient. Our standard of care in AV access intervention is vessel preparation with a high-pressure balloon and followed by drug-coated balloon angioplasty as an anti-restenotic intervention. So that's what we're going to do today, and we're going to use the Athletis high-pressure balloon to predilate lesions. There are two lesions that we've seen and have been known about previously. A focal stenosis in the mid-upper arm and a further stenosis at the cephalic arch. So here's a QVA performed on the lesion in the upper arm, and that shows a severe stenosis, but you'll notice that the vessel diameter is measured at just over 6 millimeters. Our approach has been aggressive predilatation. Usually is something like 1.1 or 1.2 to 1. But because a 7 millimeter balloon has been used previously, we're planning on using an Athletis 7 millimeter by 4 centimeter high pressure balloon, and then use perhaps a 6 centimeter long, 7 millimeter long Ranger drug coated balloon to follow that. You can see a tight stenosis over a length of around 4 centimeters. And then if we carry on into the cephalic arch, as mentioned, the stenosis doesn't look as severe. You can see this irregularity in the cephalic arch. And as I mentioned, through that area of focal webbing, there was quite a difficulty in passing a guide wire. So here you can see dilatation and a very tight stenosis and a second stenosis. We're still at low pressure here. And you can see here how resistant that stenosis is. I'm at 8 atmospheres. How are you going, Susie? Be a bit sore, dear. You're doing well. See, we're still not effacing, and then we effaced, and that was only at 10 atmospheres. So this very non-compliant balloon achieved an effacement of a stenosis that for many devices would require much higher pressures. Now I'm just taking this up to 14 atmospheres, and I think we're at a nice diameter. Okay, Susie, you might notice the balloon going up again here. It'll be interesting to see if we see any wasting through this cephalic arch. Now I think I'm through the cephalosubclavian junction there, and that's okay. Susie, is that sore at all? So that's at 14 atmospheres. We had a little bit of irregularity there, and we might just start the clock again. So let's have a look at the cephalic arch after vessel preparation, and you can see if we just add those together, probably is some luminal gain. Certainly that area that was very irregular and held up the guide wire looks much better. And we're going to treat that segment with a drug-coated balloon now. So here we can just take this balloon. We often take it to something like 0.1, 0.2 millimeters above predil. So remember, we predilated with a very non-compliant balloon to 7. With this Ranger balloon, I can get to 7.1 at 6 atmospheres. I want to do that because I want to make sure that we get good vessel wall contact for drug delivery. So I'm up to 6, and I might just go up to 7. We'll start the clock, thanks. All right, so that's after drug-coated balloon angioplasty. So I think it's a nice example of excellent vessel preparation and also good result after the angioplasties. That target lesion has come up very, very nicely. It actually looks very much like the rest of the vessel. There's a wee bit of irregularity a little bit higher up where the veins are crossing each other, but if we think back to that severe stenosis, that's an outstanding result. So we'll leave it there and hopefully that'll give us a very durable response.